Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr, I'm a GP and I'm a health informatician. And today I'm joined by Anne-Marie Cunningham. And we're going to talk about the Federated Data Platform again, because there's been some interesting developments in that area since the last time we talked about it. So very briefly, Federated Data Platform had a sort of rocky procurement, and it all seemed a little bit too weird to be true at the time. But Palantir got the contract and we sort of had to accept that. Anyway, things are looking a bit different now, aren't they? So Anne-Marie, do you want to introduce yourself a little bit more, and then we'll get on to the meat of this.
Great. Yeah. Great to be on your podcast. Thank you very much. I am a GP who is from Northern Ireland and is now again working in Northern Ireland after being in Wales for 20 plus years.
Yep.
And whilst I was there, I kind of gone through the roots of getting involved with like NHS Hack Days, which I'm still doing, and as you have been.
I believe so, yeah.
Coming up to number 30 of that.
Yeah.
Geeks who love the NHS. And I guess this is, there's a lot that we're talking about here is essentially quite geeky and nerdy.
Yeah.
Like procurement and informatics. And now all of a sudden it's kind of hit the mainstream. And that's what's kind of particularly timely about it all, is how are these things which, people never expect anybody else really to be interested in, suddenly something that people are quite interested in. So as part of my geekishness, I have worked in digital health in Care Wales, before that one of the health boards. I work part-time in the Department of Health in Northern Ireland as well. A lot of all of the things in the discussion about the FDP are applicable to England alone, because health is devolved and how we manage data is devolved to Scotland, Wales and Northern Ireland. So, but for me, and when I was working in Wales, I was also a founding fellow and a founding council member, and then vice chair of council of the Faculty of Clinical Informatics.
Yes.
Who wrote a paper about the FDP and what was going on with the procurement. Now, I'd already left the Faculty of Clinical Informatics towards the end of the year before that, but I was aware of this coming out and being coming along, and I suppose I'd waited a little while before I wrote this because of the things that were going on and what was happening.
That's right. So you've done a really good Substack article, and there's some discussion on LinkedIn that links to the Substack article. I'll put links to both of those in the show notes. But essentially, the big issue here is that the Faculty of Clinical Informatics had the temerity to write a paper that was not singing the song and clapping along with the Federated Data Platform's purpose and its procurement. It wasn't actually actively critical either. It was quite a balanced investigation of what is needed and what this thing provides, and the sort of questions that a procurement should ask to get good value for money. And their reward for publishing that was seemingly that they were crushed to death by the weight of political meddling. So I won't say that everything within the faculty was roses at the time, but one of the things that went wrong was they were very dependent on NHS England funding, as they were a body that was getting going. And actually NHS England benefited a lot by the existence of the faculty, because it brought together a lot of knowledge that helps digital things done well in the NHS. It encourages things to be done scientifically and clinically safely, and includes the right voices. So that's why NHS England was funding it, because it needed to exist. And sometimes central bodies, governments have to fund things that need to exist. And but that funding all evaporated, didn't it, overnight? Because for many reasons, but it's difficult to escape the feeling that the centre was not minded to help the faculty when it hit its problems, because what we're talking about in terms of rescuing the faculty, it would have been pocket change, really, money for an organisation like NHS England, and they didn't. So there was a conscious decision somewhere to not help.
I mean, we do know the context here in 2022, we'd probably first started knowing there was this organisation of NHS Digital in England happening. There was some uncertainty about how things were going to be. There was some kind of mood music that really there was, what was going to be happening with the funding. And then this paper was published and in draft, and as we said, we've heard. I think there have been, there was Mark Bailey who has commented on the Substack, said, yeah, there was, he was
It's
saying
more complicated than that.
More complicated. It was more complicated, but certainly there was this feeling that as John Hoeksma, who's really over time, when he was involved with digital health, been the person who documented this. It was been some very good journalism all along about the FDP, and said yes, he had been told by some people that this paper that was published by the FCI, and there were the two authors of this, Alan Hassey and Peter Short, are not the kind of GPs that are known to be radical or tinfoil hat kind of people or anything. They're really dedicated.
Well, that paper's online, so I will link to that as well, and people can read it and make their own judgment. But it's a perfectly balanced thing. It's very scientific and very rational. For
this to be painted as being unhelpful, that was the word that was used, that this paper was unhelpful, which is, I guess there's lots of power dynamics in there, isn't there, about that the role of the FCI is to be helpful to NHS England, and that being helpful would not be writing anything that could be perceived in any way as being critical of FDP.
Yeah. It's weird, isn't it? Because if it's a really good idea and it's definitely going to help, then it doesn't matter. A good idea can withstand some robust challenge without falling to pieces. So the very fact that they're so afraid of criticism makes you worry. And I remember at the time, I was the chair of the Health Informatics group of the Royal College of GPs. And that I did that throughout the whole period that this Palantir procurement was going on, and quite a bit of time before, in that sort of immediate COVID period. And it felt strange that there was such alacrity to choose Palantir, a company that really have no pedigree in health, have never shown any interest before, and all of a sudden are desperate to be the, as they describe it, the operating system of the NHS, from which we'll never extricate our data. And we were very uncomfortable with all this, but it was quite difficult at the time to say where that pressure was coming from, because we were being told this is a perfectly normal procurement, there's nothing to see here. But it turns out that behind the scenes, there were strings being pulled, and it's only now through the Epstein files, and that's cascaded into the Mandelson situation, where it turns out that Mandelson's company, Global Counsel, were being paid by Palantir to inveigle with themselves within the NHS. And it started to incriminate even other people around that orbit as being people who've been pushing for this platform to be installed in the NHS come hell or high water, whether it's a good idea or a bad idea. They were paying to get it installed.
They were paying, and some of that was coming out definitely before even this paper. I mean, the watermelon cocktails story that had come. So there was in some ways an awareness. There clearly was an awareness that there were things that were happening with Palantir, but it wasn't as if everything was just lined up in the same way that Mandelson's links in, and even now, of course, even more is emerging about it. So,
it was all very strange at the time, and there was an absolute refusal to have any open discussion about the choice of whether the choice of Palantir was appropriate. And I remember the watermelon cocktail story, and we actually, I remember we tried to do a debate at Rewired in 2023, I think, with Corey Kreider and myself and Louis Mosley, who the very famous grandson of Oswald Mosley of the British Fascist Party. I'm sure he's not a fascist, but his grandfather was. But he didn't want to do that debate, so we had a cardboard cutout of him made, and we sort of did a proto debate discussing the issues, and in that cardboard cutout he's holding a watermelon cocktail because of this exact story, that, you know, over watermelon cocktails with Matt Hancock and what other Tory MPs were around at the time, the decision was made that this was going to happen. And procurement law, we don't need that. A good idea, science, we don't need that either. We're just going to do it.
And I suppose it's not like naivety. I think it's not naivety, but I'm going to say it's not. But, you know, in the summer of 2021, I actually participated in a podcast with Ming Tang. It was on for Daedalus, and we were talking about emerging out of COVID and how data had been managed. I had a story about in Wales what we'd been able to do we'd written our own vaccination software built on. We were the only part of the UK that had used an in-house team to develop on top of a child health system that had been developed in-house by Digital Health Empire Wales. And so we were able to use that for vaccination, to monitor, to check up on stock levels, to do all the different parts of it, to whatever. And that had allowed Wales to get faster than any other part of the UK with vaccination, so that we were vaccinating faster, certainly in the earlier part. So that shows that you can actually have data platforms that are built within the NHS for it to be used by the NHS. You do not always have to go off and get something from outside. And, you know, we'd managed to pull that off in that time. And so by summer 2021, we were talking about that. And Ming was talking about this work that they were going to be coming up with, this Federated Data Platform. There was some mention about COVID and how it was good with COVID data platform that they had developed, that they could sort of see the benefits of this. But it was not, there was no mention, and I didn't bring it up, that Palantir had that contract or how this would be coming. And I was just asking very genuine sort of questions like, oh, you know, you're planning on getting this GP data in, because I think at that time there was still talk about the GT data platform for pandemic, for general, for research, that was still on the cards, even though it's been a little bit, I think, paused and then maybe coming back. But you know, it was an issue. And I was kind of saying to her, so you're going to get all this GP data into the middle, and then when you give it back out, say to the ICB or ICS to be able to do something, yes, it's going to be like federated, we'll have data and it'll be moving around, be plug and play. You can come along with your own data source, plug this in, be able to integrate it all. So it was very clear, and it's interesting, of course, because she was very clear that GP data was going to be part of this, but within a year or so, they were very clear, no, GP data won't be part of this. And then as time went on, we now know that Matthew Spindles, whilst he was in Chelsea, you know, whilst he was a chair of a board, was kind of saying, yeah, do consider, certainly locally, and trying to distinguish, because none of us are quite clear, what does it mean for data to be in FDP locally versus centrally?
And the thing is that ICBs, lots of ICBs have already got something that does this, because they have this need. They've always had this need. So they've evolved the software that does it. And then they've been told, now you must use the FDP, because I think what it's looking like now is it's embarrassing that they've paid all this money for a platform which is centralized, but at the same time it's also federated. And we've paid this money, so you must use it. And there's so much contradiction. So we were being told, as you say, that no GP data will go into this thing because people were concerned about the privacy aspects of that. And GP data is so rich and detailed that there is no such thing as anonymizing or pseudonymizing that record, because it is in itself so rich that it has detail in that is unique to you globally. You know, if you have 3 children on 3 separate dates, that alone, just knowing the dates of birth of 3 different children it's unlikely there's anyone else in the whole world that had 3 children on those 3 exact same days. That's identifying. So if you've got some access to some other corroborating piece of, some collateral information, like say their Facebook feed, and they tell you what dates their children were born on, because people tend to talk about that kind of thing, you can actually link their record to them personally.
Yeah.
That's the sort of thing where people are concerned about, quite rightly. And so we were told there won't be any GP data, but then at the same time, that was being pushed for behind the scenes.
And I suppose there is a bigger question, which I'm sure you have kind of covered in the in the podcast in general, about data and linking it, and for whose benefit is it. And people look to places like Estonia, where they've got a single unique identifier used the whole way through the system. Everything's integrated. Everything seems to be okay. And then you've got places like the US, where they really don't trust different parts of the system, and you really do try and keep the tax data separate from the health data. And then through companies and for political purposes, you can decide to bring all the data back together and merge it and use it for purposes that people are not happy about. So the governance over data and being sure and clear about how it will be used and what the trust is really important. And now I think we're all just even more sensitized to this. There's a WhatsApp group which I'm in, where yesterday somebody was posting that they'd noticed on an EMIS template that they were being asked to say when people were being registered, how long they'd been out of the country and when they'd come back. And everybody's like, why is that question in there? Why is it there? When I tried to look into it myself, we don't have, it seemed to be okay. Well, it might have been something that was about 10 years ago, but it's still been asked that way. Why is it suddenly? So I think we're all just much more sensitive and clearer.
Quite rightly. And I think the tide is starting to turn. So even a few years ago, when we were raising issues with, say, for example, Palantir, as are they a fit and proper company? Back then, people were saying, look, I think you're a little bit overreacting here. They're just a company, Marcus. What's your problem? And I was on podcasts in 2021, 2022. I was doing this massive campaign with Foxglove against Palantir. Now it's looking a little different, isn't it? So what's emerged about Palantir in the last few years is really, certainly in the last few months even, the way that they have supported ICE deportations in the States. So this is both an example of a company that is actively doing bad things with data, but it's an example of what you just said as well, which is government overreach with data. So the American government is using Medicaid and Medicare data to target people that they think might be illegal immigrants, whatever their definition of that is, which changes on a daily basis anyway. You can't look for logic there, but what you can look for is an example of when states go bad. And we have to design our system here as though the next government is going to be fascists. Mm-hmm. Let's assume whatever current government you've got is fine, but you design everything so that the next lot you assume they're going to be fascists, and you design so that they can't get data and use that to target people. So, there's the very well-rehearsed example of when the Nazis rolled into Amsterdam. They were able to find all the Jews from the records that were kept in very detailed records by the government. And that was actually kept for the right reasons. I believe it was kept because they were entitled to certain taxation differences based on religion. But the Nazis immediately used it to go around all that. So you have to design your systems as though the next gang are going to be reform or the Nazis.
And that's true. Because of COVID, we realized that there was different uptake and different effectiveness depending on your ethnicity. So there was more effort, certainly in England, about trying to record ethnicity into records. So, all these things, they have a good purpose, but they could have a nefarious purpose. And therefore, it's through the governance and who actually has access to the data and how they might use it. That's important. And I think sort of in parallel then, this work of Palantir and the contract with health also had that they had been winning contracts with the MOD. And another very, I'm going to say, it's quite nerdy and geeky, kind of legal lawyer, David Allen Green. He's done some work looking at that procurement and how that had worked, and actually just the failure of what had gone wrong with the public procurement there. And it's really the same issues that we're sort of seeing, or I say that you could say, with health. And he kind of defines about that there were 6 things. That one thing is the money. Why do people want these? Public procurements have a lot of cash, very reliable payers, don't terminate them.
Yeah. Government contracts are a license to print money. Delivery is optional. Delivery is absolutely optional. So you get the money, whatever happens.
Optional, even. Yeah. Not even the delivery, but even being clear about why you actually need this or what it's going to deliver. Then he's also one of the classic things in here was about, like with Fox and Glove and the Good Law Project, when this was published, the initial time that the contract was published, the vast majority of the pages in the contract were redacted. Yes. And the reason was because they were still negotiating some of the elements of this. And the same thing happened with the MOD one. They'd said, there's commercial confidentiality around this, which David Allen Green had said is utter balderdash and complete flapdoodle, which is wonderful. I think
it's incredibly, it's disrespectful of the entire population and all the taxpayers and everybody who respects the rule of law to say we're going to have a contract and we're going to have a procurement and everything will be above board and done properly and transparent, and then redact a lot of that contract. And when you're asked for the reason for the redaction, they will tell you it's commercial in confidence. And you think, well, every contract is commercial in confidence. They're all commercial agreements. So that is not a fit excuse. And you can only imagine that possibly even the suggestion that they're still negotiating it is why they can continue to have it redacted. And of course, in that situation, there is no incentive for them ever to stop negotiating it. There is the side issue, well, it's a pretty central issue actually, of how can you award a procurement and when you are still negotiating it? You've either finished negotiating it and you hand over the check and you get the thing, or you're still negotiating it, in which case I would not at all blame all of the other bidders for getting together and suing, because that is not how procurement's supposed to work. The negotiations are done by the time you award a procurement, surely.
And the third thing that he mentions is this idea of favouring large incumbents, which Palantir had never been, but had become, because they'd started off with this £1 contract, then 100%. Got a larger one through COVID. So again, it was the suspension of the rules during COVID, which allowed a contract to be awarded without sort of going through things. But then they became the incumbent. And when I posted about this on LinkedIn, somebody who'd been another competitor, part of like UK Cloud, had been part of a consortium which had came in and made a sovereign data program for this, no longer actually in existence, possibly because of all of the uncertainty of not being able to win these contracts against large external incumbents who are in the habit of buying people watermelon cocktails, etc.
Yeah.
So you have this about the incumbents, then there's an element around revolving doors, and this is the same in every sector. So you've got Matthew Swindells, have been the chief executive of the NHS, then moves, becomes an advisor to Global Counsel, Peter Mandelson's company, who also have Palantir in the contracts. Becomes the joint chair of several Northwest London hospital trusts, is pushing, as it's come out even in the last month, was actually pushing, even though he was meant to be in, his argument is that he was not involved in any of these elements. He would not be involved in any of the decisions about Palantir in it, but was still pushing for GP data to be got in to these projects locally, not centrally, but we're not quite sure what that means.
What does that mean?
This kind of principle is that these contracts end up working for the contractors rather than what we would really expect that they're working for us. And then you've got the whole element, which is, I think, what everybody in health is very aware of, is actually IT and IP kind of lock-in. If you start using that platform and everything is built within that, then you can't really easily move back out of it. Whilst all the time and effort that you've maybe been doing locally, building up things with data teams and products that you've developed, you're actually there, you're in charge of them, you can use open source technologies for them. You actually have control. The only way you can keep on working with Palantir is if you keep on paying Palantir. Otherwise, everything is lost.
Yeah. And a lot of the domain knowledge that's gone into building that platform, we've essentially given them for free. So once someone is announced as the contract holder, if they need consultancy, essentially, if they need help from within the NHS, they will go and ask for it, and they'll say, what data fields do you need as an ICB? And they'll go and ask around all the ICBs. That's consultancy that we provide to them so that they can build a better product, which they then charge back to us at the mere snip of whatever it is, nearly £1 billion, I believe it's now estimated at, being the total contract value, including the costs of deployment and staff training and all the kind of things that go around that. It's ludicrous, and it could have all been done differently. And I mean, if we want to do something about this, there is a solution, which is to in-house it. Interestingly, the NHS did this before. We have something called the NHS Spine, which provides services like demographic lookup and e-prescribing and referrals and other things like that, central services that need to be shared everywhere. And that was originally built by an outside set of companies, and NHS Digital, as was, in-sourced it, and they rebuilt it in-house. They did get some consultant software development help to do that, but essentially they brought it in-house and own it, and it is now built on open source components on source code that's owned by NHS Digital, now England. So we did it before, and this is just a data platform. It's built on Apache Spark and other similar open source projects, so we could build it ourselves. And there's one other thing that's changed in the past 6 months that really accelerates this, and that's agentic coding got good. And now the cost of delivering high quality, clinically safe, tested software has dropped by several orders of magnitude. And that means that an in-house NHS team could replicate something, especially as we have the Federated Data Platform as a template. We have its data sources, inputs and outputs. We could use that.
When you sort of say that even companies like, they're supposed to be like Salesforce, companies like big CRM are feeling under threat from, why would, if you're a small business, you don't need to in a way be able to outsource all these things. We know that there are just the same way we're talking about security and governance of NHS data is very important. If you're developing code, it has to be safe code, but these tools can actually help you with definitely making it safe. It's not that everything is going to be, I'd made a little app using Claude Code to be able to, like a question bank for a quiz that I was taking part in. We didn't do very well, but I can still work on it over the next year so we can do better next year. But one of my friends, my husband's friend said, comment on LinkedIn, have you SAS tested and pen tested? And I said, no, but I went back and I said, Claude Code, we did. They come up with the different elements. We ran it through. It actually started making some decisions. Like I had a bulk upload you could upload 100 questions at a time to be able to make it easier to add to the question bank, but it thought that was too many and said, maybe we only do 5 at a time as a way of like actually managing things coming in. So it can actually think through all of these things as a partner with you. And that's me, who's a GP, who, has had a GitHub account set up since 2013, but not really used until this year. So I think
things are changing rapidly.
Things are changing rapidly. And if you have a developer and people that can work with these safely, you can take these things. I was able to do things about using open source prescribing data, which I'd wanted to do for years. And I was able to put that together. So I think with regards to data and getting the code to be able to work with it, it's getting harder and harder to argue why exactly you should be insourcing these things. That's what people are going to be wondering. Why are you outsourcing a software, it's platform as a service, not even software as a service? Why are you outsourcing all of that when you could? What is really the reason for it? And I think that now it's so accessible that everybody can start playing with these things and understanding that themselves. It used to be you could come along to an NHS Hack Day and see how very quickly people could wireframe something, and you still should do that, absolutely, next 2 weeks, in the 20th. But now you can actually start playing with this yourself and understanding it. So
it's amazing. It's switching a lot of people onto this stuff. I think it helps us detect the £1 million chair as well, because when somebody shows you a piece of software and says it costs £500 million, how can we don't readily have a frame of reference for saying, no, it doesn't. Whereas if somebody shows you a chair and says, this is £1 million chair because it's so good, you can immediately say, there's no chair in the world that's worth that much. So being able to try out these kind of coding tools helps us to realize how easy it really is now. Now, I'm a professional developer, and I do a lot of this stuff at scale, and I'm not at all underestimating the difficulty of doing good stuff at the scale of a country. So we're not saying that people hacking, GPs hacking on their own are going to fix this, but a team of resourced, clever people put together inside an organization that is for analyzing NHS data. And I would say that organization should not be NHS England or Department of Health and Social Care. It needs to exist outside it. They could absolutely build this stuff. And some of the artifacts that we have. So Palantir published, for example, what they call the canonical NHS data model. They put it on GitHub with some degree of fanfare, suggesting that they'd now solved the problem of our data modeling issues in the NHS. And it's comically incomplete, but it's also got Palantir all the way through it in the paths to various APIs. And so it's not a complete data model, but it is an interface to something that the FDP has. If you have that data model and you feed it into an AI, you can say, build me a thing that expresses this exact API, build the backend for it. And because of that tight spec that you already have written in code, you can do this kind of stuff at high quality. Then you have to apply the clinical safety, the cybersecurity, the medical device legislation. Some of that is complex and hard to do, but there's no reason that we can't do it. If Palantir can do it, if any existing human intelligence can corral this work to be done, then other intelligent humans can do it somewhere else. It's not magical. It's not alchemy. It's perfectly doable. And I think that is what we have to really expect. Yeah. I also think there's a very important step there, which is we've gone backwards by merging NHS Digital into NHS England into DHSC. I can appreciate there's a certain amount of duplication there, but the existence of NHS Digital was not accidental. NHS England, you can take away and you can set it on fire. I don't care. I feel for the people who are left in limbo there, but the organization is a waste of space. NHS Digital is different. It was separate for the reasons we were talking about around the sovereignty of the data being separate from the government. And it was insisted on way back when, in the late 90s, early 2000s, the NHS Information Centre, I think it was called back then, was there to separate data about patients from the government so that you couldn't have an ICE data grab where they'd say, show me anyone who's got a medical record that says that they have no fixed abode or that they live on a fruit farm in a caravan because they're probably an illegal immigrant. We can send in troops and round them up. We have to defend against that. The border force have their methods and they do their thing. That is something that you need in a country, but they should be subject to the rule of law, and they should not ever be able to use your medical record as a way or as any kind of data source to determine who they should target next. That's a complete, we as clinicians are the ones who have to stand in the way.
Yeah, well, we as clinicians, and we need to support the public and our patients and citizens to be able to understand this. This is and it's the antithesis in a way of seeing just the patient as a consumer. I was actually reading back over some things that Julian Tudor Hart had written, and in his work about like the new kind of doctor, and actually seeing one of his concerns and some of his later things that he'd written about. So people that don't know Julian Tudor Hart, he was a very influential GP who could have worked anywhere but chose to work in one of the poorest areas in Wales, and was doing research at scale before anybody else was doing this. So he believed in systematizing care and going through. He measured the blood pressure of everybody in the village before anybody else. Had a piece of paper in the Lancet that showed he'd reduced mortality. But he was critical of, even with research, whenever people came along and were paternalistic to the population. And when he got people to come along and be involved in research in his community, and his wife was involved in this as well, they used to talk and sit and go back and present the findings back to people and get their feedback. And they even said even the people that didn't participate in the research, they talked about it in a generalized way so that even they could understand what was happening in the community that they were in. And I think that's the way we talk about, working with communities now, but we have to see our populations not just as people that we're protecting, but as people that we're actually managing to inform and know how to be really participants within this. So,
yeah, I completely agree with that. And that's a very hard thing to do, I think, with the resourcing levels of primary care at the moment. That's been sort of on a gradual attrition since a peak in the sort of early 2000s, when it was suddenly massively resourced, and then they've just been clawing that back since, making it harder and harder.
It is hard, and we do hope that there will be, if you looking around at how contracts, etc., work. I sort of always just a feeling in some ways it's like, general practice. When you look at somebody that's healthy and rich, they're able to plan a lot for the future and think about the future because it means something. And in general practice, because of all the tightness and constraints, instead we're thinking more about what's next week and what's next month and what's the rest of this year. So it's hard to shift into that frame of being worried and concerned, and I suppose keeping yourself up to date with what these things are going on and what might be happening. And also there is that feeling like it's not about being tinfoil hat and being conspiratorial. These really are genuine live issues. And AI and things. We in another WhatsApp group, we were like talking about this, and somebody says, "Oh, we're discussing this. It's political," and it's like, well, we know it's very Trump said. Well,
everything is
of
political eventually.
Everything about AI is political. Which platform you're using, all these bits, how the data is used, all these things. And now more than anything, it feels like it's not about being political. Doesn't mean just give me more money and I want to, it's about being aware of all these elements around data and how it's used and where the power is, and following the money and following the power and seeing how these things link up.
Yeah, I think this story tells us more than any other story recently that, if you follow the money, follow the power, and you can start to see why something went wrong. So this project does sound like it's gone badly wrong. It was started for the wrong reasons, and if you follow the money, you can see how that it got going. But yeah, I think it's been hugely interesting to see, and very important that we point out and start to link all the things for people. So joining the dots as we have on this show, we've been following the story, but so much has come out recently that it felt we had to do, a revisit, as it were, and say, look, this is bad. Palantir are bad guys. They are complicit in Gaza, complicit in ICE. These are human rights abuses. And we've got that same company working in the NHS. And it's been called for by politicians now that, and the BMA, that we need to start the process of getting Palantir out of the NHS. And I fully agree with that. I really tried to prevent them getting into the NHS at the time, but back then it felt like nobody was really willing to listen. Maybe the evidence wasn't there then, but the evidence absolutely is there now. They've bought their way in illegally into a contract that they should not hold because they are not the right company for it. Fine, go and wage war somewhere else. The world seems to have the concept of perpetual war. There are arms companies out there that do that thing, but like I've always said, they need to stay in their lane. We do healthcare, and we do that with a code of ethics, which we decide. They do warfare, and they can do what they want over there. But what we don't want is warfare companies doing healthcare.
Yeah. Unless they were somewhere or other exceptionally good and had come along, but I don't think we have any evidence yet to suggest that.
No. Well, I think that's been a lovely roundup of the story, and I think there's a lot to process in there. I'll put lots of links into the show notes. So if anything of this has interested you as a viewer, go and have a look at the description, which will have lots and lots of links referencing essentially everything we're talking about, because we're not making this up. This is stuff that is in the news and in mainstream media. But it's important that this message gets out, and there are things we can do about it. This is it's not an unsalvageable situation. We've got absolutely the ways to get out of this. Anne-Marie, thank you very much for joining us. And I feel as though there's definitely another episode in talking about that. The stuff that you were talking about about GPs and the way that they bring their patients into research and closing that loop.
I think it's not just about research, though. It's about being aware of how your data is actually there and being managed and being used, and our response. What does it really mean to work in partnership with people? It's not about being transactional. It's about people knowing and understanding that we're on the same page about doing things. But yes, there's a lot more, I think, in the future will be about AI and how things are shifting and changing.
Completely. So, well, thank you very much for joining us, and we'll definitely do another episode to talk about that. So thank you very much, Anne-Marie. Bye-bye now.
Thank you. Bye-bye. Great joining you.